And without further ado, I think we'll go straight across to our first chairman with his excellent panel. So Dr. Charles Powell from New York City, Mount Sinai, famous Mount Sinai Hospital. Charles, over to you for the first session, and thank you so much for participating.
Well, thanks so much, Roger. And I'd like to thank the Counter Foundation for supporting this event, as well as the Royal Society of Medicine. It's truly our pleasure to lead off and present to you our perspective in terms of preparations for the surge and our observations in terms of the management and presentations of people who had COVID-19 and had respiratory disease. I'll start off, if I could, by introducing our panel of experts. We have Dr. Anita Simmons from the consultancy at the Royal Brompton Hospital in London. We have Dr. Richard Eckler, who is the director of the Medical Intensive Care Unit at the Mayo Clinic in Rochester, Minnesota, in the USA. And we have Dr. Eva Polverino, who is pulmonologist and senior investigator in respiratory infections in Barcelona and chair of the Respiratory Infections Assembly at the ERS. So our goal today is to walk you through our perspectives from our various locations around the world in terms of how we prepared for the surge and how we made observations in conjunction with colleagues around the world in terms of the unique aspects of COVID-19, how we manage patients with COVID-19 during the surge, and what we have encountered after the surge. I'll lead off, if I could, and just tell you our perspective. Our perspective, of course, began as we learned, as the rest of the world, that there was an unusual epidemic in China, starting in Wuhan. And we learned that that epidemic in Wuhan was spreading. It was spreading throughout China and also had made its way to Europe and to the United States, starting in the state of Washington. During this time period, our health system, like multiple other health systems, began making preparations to provide the care that would be necessary for a surge in a pandemic. In order to understand more about the medical aspects of this pandemic, we were in communication with physicians who were deployed to Wuhan. We have multiple academic and clinical collaborations with physicians in Wuhan, specifically from the West China Hospital in Chengdu. We set up a teleconference with physicians who had been deployed to Wuhan in February of 2020, where we learned several key aspects from their observations. And just two takeaways to share at this point in time would be, first, that the proper use of protective equipment prevented subsequent infections in healthcare workers. And the other takeaway that was important for us to learn was that in patients who had progressive respiratory failure and exhibited markers of active inflammation as assayed through a variety of different biomarkers, there seemed to be a signal of positive response in patients who were treated with steroids. So around that time, we began in earnest to make preparations again to prepare for the surge that we'll get into more detail. And then what we'll focus on during our session is what we all observed as patients came into our various medical centers with COVID-19 respiratory failure and pneumonia. What we learned was that there were some unique aspects of this COVID-19 pneumonia and ARDS. Specifically, although the patients would universally have severe hypoxemia, the physiology as demonstrated by mechanics on the ventilator was different than what we had typically seen in ARDS due to other infections in the past, mainly if we look at the lung compliance. Secondly, we and others noted that there were alterations in the microvascular regulation of blood flow and evidence of thrombosis, both in large vessels and in small vessels, with a signal suggesting a potential benefit of treatment with anticoagulation. Thirdly, we also noted that it was possible to support patients with respiratory failure using non-invasive means. high-flow nasal cannula or non-invasive positive pressure ventilation. And there are also potential benefits of using tracheostomy early in the course so that patients can be mobilized quite quickly, get the rehabilitation they needed, and to free up acute care beds for new patients who would need them as the surge continued. And finally, what we observe now, as the surge is over in New York City in particular, is that there are quite a few individuals with persistent lung injury and respiratory failure following recovery from the acute phase of COVID-19. And that we need to better understand the nature of this lung injury after COVID-19, whether it is progressive, whether it is reversible, and what the appropriate modalities are to help patients recover more quickly from COVID-19. So what we're going to do next is we're going to travel around the world and talk about what the pre-surge preparations were in each of our different areas. I'll start in New York, then we will go to Rochester, Minnesota, then we will go to London, and then we will go to Barcelona. So from New York, our early projections using modeling that takes into account the prevalence of the virus, the rate of infection, and the absence of any social distancing at the beginning of the pandemic in New York City in March, the models projected that in New York City, and in particular at Mount Sinai Hospital, we can anticipate 22,000 patients requiring hospitalization in the Mount Sinai Health System. That's a huge problem because at our baseline, our 8 hospitals can accommodate 2,500 patients. Like all other hospitals in New York City, we prepared for a surge by increasing our capacity by 50% to get us to 4,250 beds, but still far shy of the 20,000 that might be needed in the case of the maximal projections. But as social distancing was enforced in New York, beginning around March 18th, we saw the peak number of hospitalized patients drop by 1 to 3,000 every day, such that by the time we hit the peak at Mount Sinai Health System on August 10th, we had 2,200 patients in our health system. So lesson number 1 to us was that social distancing has a significant impact on outcomes and deaths related to COVID-19. Now, around this same time, we also made preparations so that we would have enough beds for patients. We did that by creating beds in spaces that don't normally accommodate patients. In common areas within the hospital, in tents across the street in Central Park. We increased ICU capacity by putting ICU beds into units that were no longer being used, such as the post-operative care units, and by putting 2 ICU beds in every ICU room that could accommodate it. So those were the efforts made to provide beds. We did the same efforts to increase the number of staff available to care for all of these patients. We recruited staff from around the country. We trained them up to be able to be competent in the skills necessary for caring for patients with severe COVID-19 infections. We used a tiered model such that we would have a skilled intensivist, an experienced intensivist, manning large numbers of individuals in segregated teams. Finally, we also increased our supply of ventilators by buying 800 ventilators from around the world and by creating pathways to repurpose home ventilators, BiPAP machines in particular, so that they could support patients in the critical care setting. Now, I'd like to move on and hear about the experience from Dr. Eckler in Mayo in terms of the pre-surge preparations that were performed in Minnesota. Dr. Eckler.
Well, thanks, Dr. Powell. And I'd also like to, of course, thank the Cantor Charitable Foundation, the Royal Society, and Professor Kirby for inviting us to weigh in here from the middle of the United States. Because of our location, we're a little bit isolated, I guess, so to speak, and we're able to learn some of the lessons as you did out of China through our same colleagues in Chengdu and the West China Hospital, as well as others. And then we also had the good fortune that it took a bit of time from the first cases on the West Coast and with you out in the East Coast to, before we started to really see things here. So we had the added benefit of a little bit more time and learning through your experiences. And so many of the things that you were doing, we were learning what was working, how the PPE would work. I think that's one of the biggest issues we've struggled with are the definition of aerosol generating procedures, which maybe we can talk about a little bit later, and how then to protect yourself based upon the level of what we call these AGPs or aerosol generating procedures. And there was significant consternation with staff as to whether we were protecting ourselves as well as needed or not. And we had some experience with that from our HCID team, our high consequence infectious disease team, that we dealt with Ebola and the previous MERS epidemics, and or at least in preparation for those cases, where we really learned that sometimes more could potentially be less. And what I mean by that is we often found we were contaminating ourselves trying to get out of these elaborate isolation suits. And so we really looked for the minimum PPE that we could use and also to make sure we had enough resources. And we really did find that the basically modified contact with airborne precautions really has protected us well for AGPs, and that just a modified contact and droplet type of protection that most everybody is using really worked well. We've actually had no infections in our medical ICU, which is our COVID unit, after now about three and a half months or more of treating these patients. So from the AGP standpoint, and open communication, I think, is something we really learned. Not to reiterate a lot of the things you covered, I would also expand upon some of the safety and teamwork. We did have expansion of our team such that we could use even fellows and APPs to the kind of the peak of their license to make sure we were optimizing as many folks as we can to provide critical and acute care without having redundancy in the team structure. And then also really emphasized PPE spotters or champions to make sure that everyone was donning and doffing, since we do again know that that is really one of the areas that we're seeing a potential for infection of healthcare workers. And then two other observations we noted early on, especially since, again, in the upper Midwest here, and especially in Rochester, there's a small city with a major healthcare center. We're predominantly a Caucasian population, but we did note right from the beginning that about 30 to 40% of our total COVID numbers, and this has persisted through to today, have been our non-English speaking minority populations in this area. And so right away, we were starting to see that there are probably some other either social determinants or some infectivity or potentially even, I suppose, a physiologic basis for that. But we were very aware right away that certainly some of our populations were being affected more than others. And then finally, I would mention the one thing that really struck home to us was the potential for isolation and moral injury occurring to both our patients, their family members, and us as a healthcare team. And so we really worked to ramp up video conferencing as much as possible. We, unlike several centers, or I understand most centers, we're actually making some exceptions for at least drastic life-changing decisions or end-of-life care to actually allow visitation, and we can talk about those details as well. But we were really quite aware that there's a potential for all of us to become quite isolated, and how much of an injury that could be to our patients and their families as well.
Thanks, Dr. Eckler. Dr. Simmons, the perspective from London, please.
Yes, in London, our peak surge was at the beginning of April. We too had seen what had happened in China and nearer home in Italy, and our modelling data showed that unless there was a very considerable increase in capacity of the NHS, then it would be overwhelmed. And so there was great steps taken to increase critical care capacity. Many units doubled or trebled in size. Respiratory units, high dependency units increased, using all the tactics you discussed, extending into other areas within the hospital. But of course, it's not about beds, just beds. It's about the staff to manage the patients in those beds. And so, as you did too, we had training programs to upskill staff. Staff moved back in, our research staff moved back in to augment the teams. We had mega teams of combined cardiologists, respiratory physicians, intensivists, anaesthetists, and all that contributed to be able to provide the facilities. It was expected there would be a pinch point with ventilators. In fact, I don't think we did run out of ventilators. As a scheme, and a number of relatively simple CPAP machines were developed very quickly, but we were able to use our facilities. We too used high-end ventilators that were usually used in the home to step down patients from intensive care and manage the group that way. Finally, I would add that shielding works. So many of our patients who had existing conditions shielded at home, and that seemed to have a significant protective effect and reduce the admissions from those with significant comorbidities. Thank you.
Thanks, Dr. Simmons. And Dr. Palvarino, perspective from Barcelona.
Well, I'm the last one, but it seems like we are going back in the past to what happened at the beginning of this pandemic, because I'm Italian. I'm from the country that was the first step in Europe after China, but I live in Spain. It was the second country hit by this pandemic. My personal experience was, I would say, difficult, strange, because I was here in Barcelona. I was receiving emails and chats from my colleagues in Italy, something really scaring, people trying to invent new ventilators, filters, trying to get protected, people dying everywhere, no beds. So the first shock was really, really tremendous. And while I was here, I do remember my main duty was to try to inform other colleagues here in Spain about the fear, about the risks we were as close country. So I do remember on 1 week I was looking for ventilators to send to Italy. Italy was Italian colleagues were desperate to receive 500 ventilators. After about 10 days, we were looking for ventilators here in Spain. So my point of view is partially different because we had no time to learn. We thought at the beginning that the Chinese virus, and permit me this expression, was similar to the MERS or SARS, that was going to stay in that area of the world. Italy was not prepared to these. That's the reason of possibly increased mortality, particularly of the high rate of healthcare professionals getting infected. We had, I would say, a couple of weeks here in Spain to see what was happening in Italy, to learn the lesson, the few lessons we could learn because it was at the very beginning, and to prepare the hospitals. Just to give you an idea, in my hospital, that is one of the biggest in Spain, we've immediately changed, disposition of different words and increased the number of ICU beds from the usual number of about 55 to more than 500, almost 600 ICU beds. So staff preparation was a constant, effort. So all pneumologists, all intensivists and internal medicine professionals were involved in preparing other doctors of the hospital to help us with the care of COVID patients. And to transform and to learn day by day was about the patient we were managing. So, it was really difficult. We had no instruments to manage this situation, but I think we have learned a lot since then. And unfortunately, we are now managing a second, or I would say a mild second wave. The number of COVID patients are increasing, but not so quickly as at the first time. And the difference is clear. We learned something important like social distancing, social intervention to get people aware of the risks of this infection, particularly with young people. You know, young people like parties and whatever, but this is a real issue. If you go out with your friends when you're 14, you can go back with your virus at home, and you could literally kill your parents or grandparents. You know, so that's what we are now facing in Spain. So we have like to turn around again and to manage a second wave with the few lessons we have learned.
Well, thank you all for sharing. I'm hearing at least two key themes. One is that during this entire period of time, there was a international collaboration, in essence, paying forward the lessons that we learned and transmitting it to our colleagues around the world. And that's been going on since the beginning of this. And I think that's been invaluable for all of us on the receiving end. And I know we all have been transmitting the information that we can to our colleagues as well. The second thing is we can hear the sense of urgency that we all are revisiting from when we were in the midst of this surge. And for some of us, the surge has remitted. In New York City, in particular, we had a total of 220,000 cases. And now in our hospital system alone, we have about 10 patients with COVID. And at the same time, it's heartbreaking to see other areas around the United States that were quiet around the time that we had our surge, who are now experiencing the same kind of urgency that we were all talking about before. And so we hope that the lessons that we've learned will be of use to our colleagues, whether they be in Florida or Texas in the United States or Arizona. So I'd like to move forward and spend a few minutes on hitting topics that were covered by the questions submitted to us by our audience on specific topics within the respiratory disease manifestations that we saw in our patients with COVID-19. So first off, most of our patients, of course, had severe hypoxemic respiratory failure. But again, there were some patients, especially early on in their course, who had a physiology that was remarkable for the relatively low presence of stiffness of the lungs, meaning the lungs were quite compliant. And so I wanted to ask Dr. Eckler his thoughts on the pathophysiology processes that were suggested by these observations and how it would compare to, in terms of being similar or different from ARDS due to other infections that we've seen in the past, SARS, MERS, et cetera.
Thanks, Dr. Powell. So this has been an interesting topic and has led to, as I'm sure most of the viewers have noted in the literature, quite a bit of controversy, especially if you've been following some of the Dr. Gatnoni, Dr. Marini versus Dr. Tobin versus some of the Toronto folks, Dr. Fan et al. And this is what you're alluding to is what at least Marini and Gatnoni have been calling the L versus H phenotype. And what they're referring to with that is, of course, the L stands for low elastance, or in other words, improved or a bit normal compliance. And that's where I think some of the sticking point lies. There certainly is a question here of differing respiratory mechanics. And I think the folks who are in the camp that these are two different phenotypes we're looking at, there's a question, are they two distinct phenotypes, or is this really kind of a spectrum of illness, and that maybe we're inserting ourselves into, say, an early early kind of ARDS versus that later stage fibroproliferative phase that we're more used to seeing when we intubate and intervene a little bit later on in the course. So, where we're looking at with this is, as you know, or at least what's been discussed in the literature is the ACE2 receptor likely being the binding and entry point, and then the virus being endocytosed. And what the ACE2 enzyme is and receptor, as you know, ACE2 breaks down angiotensin 2. And so with the changes in angiotensin 2 signaling, obviously surrounding that, there is the possibility of pulmonary vasoconstriction, procoagulation, cascades, inflammation, oxidative mediators, really those interleukins, the TNF alpha, and the cytokine storm. And then the question there being, what are the mechanisms of hypoxia? Well, if you have a loss of ACE2, you have an increased angiotensin 2, you may develop some inappropriate vasoconstriction in those normally aerated lung fields. And so what this kind of L-type ARDS that's been posited with a little bit more normal compliance, the thought is, well, gosh, when you look at the CT scans, they really, the hypoxia is out of proportion to the infiltrates. And so it looks like this is more an endothelial side injury and probably a vascular endothelial injury that's changing some of the either vasoconstriction to those areas that are non-aerated, the appropriate vasoconstriction, or potentially losing flow-mediated vasodilation that is normally present in the other areas. And so you get both kind of a shunt physiology and a VQ mismatch related to this. And that's the thought process, at least early on. We certainly need more data on this. The debate then becomes, well, then how do you treat this? And that's where some of our usual methods for treating ARDS are called into question because of the fact if you already have a more normal lung compliance and you add a little bit higher PEEP, as we all know, there's a relationship between lung volume and pulmonary vascular resistance, and you have the potential to actually worsen conditions if you're increasing the PEEP on these folks who have more of a normal lung compliance. Now, that being said, and why there is quite a bit of debate about this is even some of your data from New York shows that on average, at least in 200 or 300 patients, and I reference, and there is should be included in our references, Dr. Fan and the Toronto group's kind of counterpoint to the Gatnoni article, is that when you look at all comers, the compliances still were down in the 20s. And so it calls into question, is this really a distinct phenotype, or potentially are we seeing something on a spectrum? And they advocate to treat this more as we've approached kind of all-comer ARDS in the past. I can tell you from our experience at Mayo, again, we've had the luxury of not being overwhelmed in the system. We've been able to kind of methodically approach these patients and intervene earlier. We also benefited from the fact that we saw the early studies or early concerns about non-invasive and high-flow ventilation, and then a little bit of a dissipation of that. And so we actually employed non-invasive and high-flow from the start, with or without kind of self-proning. And so I think we basically approached this as we had our other types of all-comer ARDS, and we seem to have a pretty good outcome with that. But certainly some discordant physiology, I suppose, on some of these measurements, definitely.
Well, I'm glad to hear you mention the possibility of shunt physiology. We have a paper in the American Journal of Respiratory and Critical Care Medicine reporting on the presence of shunt as detected by transcranial Doppler evaluation patients with COVID-related ARDS at a much higher prevalence than we would have expected, confirming, at least in this population of patients, that there is evidence of shunting, which would be different than the typical pattern we would see in patients in other forms of ARDS. So there's something, at least at some time point, that seems to be unique. Any comments from Dr. Simmons or Palvarino about this specific aspect?
Yes, I think the physiology is very interesting, and there's evidence that there is a lot of shunt and dead space, and that's why you doesn't hugely increase the work of breathing, and that's leads to the phenomenon of the silent hypoxia or the happy hypoxia, and the fact that, as we're going on to talk about, there is benefit from using non-invasive respiratory support in this group of patients, or at least in a set of this group of patients.
And to follow up on that, early on there was a thought that perhaps patients who had respiratory failure associated with COVID-19 should move right ahead to invasive intubation and mechanical ventilation. And I think the experience from multiple sites, including yours, would suggest that there is a role for waiting when appropriate and using non-invasive strategies. Dr. Simmons, I know this is your area of specific expertise. Would you like to comment on that?
Yes, it depends on the trajectory of the patient and their rate of deterioration. But the use of non-invasive ventilation, we had data coming out of China suggesting that the success with CPAP and high-flow oxygen therapy was greater than, say, in MERS. We had evidence, too, from Italy, where they're under a lot of pressure that use of CPAP in the emergency room could prevent admission to intensive care and the need for intubation. And that's the rationale, after all, of the non-invasive strategies, to reduce the need for intubation, to offload critical care units, and also to use to step down patients early from critical care with or without a tracheostomy in the first instance, and then moving on to non-invasive support. I also think that the concerns that we've had for a while about CPAP, high-flow nasal oxygen therapy being aerosol generating and discouraging people from using those techniques has not really been borne out, because if there is adequate provision of PPE, that there are strategies taken to filter the exhalate, double limb systems, proper protection of healthcare workers, then you don't have super spreading events and you don't infect healthcare workers. Always with non-invasive approaches, you have to be aware that it will fail, and therefore patients that you manage with CPAP or high-flow nasal oxygen have to be managed in a way that you can, if they deteriorate, provide emergency intubation and progress them to intensive care if that's indicated. But it may be up to 30 to 50% of intubations can be avoided using non-invasive support. I think we still don't know which technique is best for each person, whether it's CPAP or high-flow nasal oxygen. There is a recovery RS trial in progress in the UK, a sister trial to the recovery drug therapeutic trial, which will help us know which particular phenotypes would benefit. But I think we have found there is a significant role to reduce the need for intubation and step down patients.
If I can add something on this
Please.
point, as we are facing this kind of second wave, this is one of the lessons we learned during the first surge. It is clear, even in our experience, that non-intensive ventilation was really effective. We were able to manage a lot of patients with this. One of the first steps of preparation for the second wave has been to have more non-intensive ventilation, CPAPs ready, trying to avoid intubation. So absolutely in line with what Anita was saying, absolutely crucial.
I would just make one other comment, is I think we've had incredible success with high flow or non-invasive, but mostly high flow and auto-proning or self-proning as well.
Great.
Absolutely. High flow oxygen and CPAP, inclusively, I would say even more with high flow oxygen therapy. And it is, very related to the pathophysiology that has just been described. All the markers we have of severity in terms of laboratory findings go back to the pathophysiology and to development of hypoxemia over time.
Charles, I'm going to have to interrupt here. That's a fantastic discussion. I can tell that you guys would be able to talk about this for about 4 hours. So thank you so much for the respiratory panel. Excellent work.